In this video brought to you by the Hip Hope Network, we will review the keys of monitoring hip health in children with cerebral palsy. This video is intended to assist healthcare professionals. Hip displacement in CP is a consequence of altered weight bearing and a muscle imbalance around the hips. The hip flexors and adductors overpower the abductors and extensors. This imbalance causes the femoral head to be aimed away from the socket, and over time alters the growth of the femur and acetabulum. Gradually, all of this results in the femoral head dislocating. Of all children with CP, more than 1/3 will develop significant hip displacement as they grow. Hip displacement can impair the way children sit, stand, and walk. Aside from abnormal growth and development of the hips, the displaced hips can drive spinal deformity, and most displaced hips are or will become painful. However, with proper monitoring and assessment, this problem can be detected and treated to keep the hips in joint, helping to preserve function, prevent pain, and potentially prevent secondary deformities. The hip assessment in children with CP involves 4 steps. First, determine the child's functional level. Second, observe posture and gait. Third, assess joint range of motion. And finally, an AP pelvis X-ray should be obtained at certain prescribed intervals and when there is concern based on the clinical examination. Let's go through each of these steps in further detail. In CP, functional level is classified by the Gross Motor Function Classification System, or GMFCS, shown here with its original descriptions from Pelisano et al. And illustrations by Reed et al. Note that GMFCS descriptions are also available from age 2 to 6, but without illustrations. Because the GMFCS level predicts a child's risk for hip displacement, it is used to determine the frequency of hip monitoring. Since this is such an important tool, let's review the GMFCS in greater detail. GMFCS level 1 represents a child who ambulates and climbs stairs without assistance. These children have very little risk for hip displacement. GMFCS level 2 represents children who can ambulate independently, but have more difficulty on stairs, uneven surfaces, and with longer distances. They may use assistive devices for those conditions. There is a small risk of hip displacement in these children. GMFCS level 3 represents a child who requires a handheld assistive device for mobility for most indoor settings. They might be able to climb stairs with assistance, and they may use wheeled mobility for longer distances. In lower resource settings, these children might present as having limited walking without someone helping them or without holding onto objects around them, but they might be reported to be able to crawl or mobilize on the floor without help. This level is associated with a moderate risk of hip displacement, occurring in at least 1/3 of these children. GMFCS level 4 represents a child who requires significant physical assistance for mobility in the home and uses powered wheeled mobility in most settings. In low-resource environments, these children might be identified as being unable to stand by themselves and needing to be carried or helped by 2 people, but they may sit by themselves once positioned. There is a high risk of hip displacement in these children. GMFCS level 5 represents the most severe level of involvement and includes those children who are transported by wheelchair and do not have good anti-gravity trunk and head control. In environments with limited resources, these children might be identified as being immobile or having to be carried and unable to sit by themselves. Almost all children at this level will develop hip displacement. The second step of the assessment is to observe the child. For ambulatory children, this means first looking at how they walk. Look for a Trendelenburg gait, limb length discrepancy, abnormal limb position, and signs of pain. This patient has a hemiplegic gait. She does not have a Winter Gauge Hicks type 4 gait pattern where you would see excessive hip flexion, adduction, and internal rotation, and would be associated with a higher risk of hip displacement if present. However, She does have a mild Trendelenburg on the left side. Next, assess the standing position. Look for asymmetry, abnormal limb position, and the ability to do single limb stance. Look for a Trendelenburg sign or weakness around the hip, as seen in this patient, when she attempts to stand on her left leg alone. We can also see posturing of the left upper extremity consistent with left-sided spasticity. For children in a wheelchair, assess their seated position. While they are sitting, are they leaning to one side? Does one thigh look shorter than the other? Can they sit independently? In these images, we can see an asymmetry in knee positions, with his left side shorter than the right, a lean to his right with a truncal support in place, and we note that the left lower limb appears more internally rotated and adducted compared to his right. These findings suggest a potential issue with the left hip. In the supine position, observe the resting posture of the hips. Scissoring, where the lower limbs rest extended and crossed, and windswept hips, where one hip is adducted and the other is abducted, are shown here. Both postures are concerning for the risk of hip displacement. Also, note if one hip is excessively flexed, and if appropriate to your clinical setting, look at the skin in the medial groin for breakdown or irritation. Examine the child's back for any signs of fixed deformity, as scoliosis is associated with a higher rate of hip displacement. The third step of the hip assessment in CP is to move the hips. First, look for a Galeazzi sign, as shown here. In both of these cases, the left knee height is lower than the right, which could indicate a left-sided hip dislocation. Alternatively, it could be a sign of a limb length discrepancy from another cause, or the result of asymmetric hip adductor tightness. But at minimum, it tells you that this patient needs an AP pelvis X-ray for hip assessment. Next, assess tone in the muscles around the hip and the range of motion. In these videos, we can see hip adductor spasticity, which manifests itself as a significant difference between the adduction range achieved by a rapid stretch versus the persistent slow stretch of the hip adductors. Hip abduction is also assessed in the extended position, being sure to account for any pelvic obliquity. In general, hip abduction in CP is usually more limited with the hips in the neutral position than in the flexed position, so if you're only going to measure hip abduction in one position, this is the recommended one. For professionals more experienced in musculoskeletal examination, a few additional measurements can be helpful. First, there is hip extension. After bringing the contralateral hip to the flexed position to ensure the pelvis is level, assess how much flexion the hip remains in compared to the horizontal. The result is a measurement of contracture in the hip flexors. And with the patient lying in the prone position, femoral rotational assessment can be performed. Internal rotation is shown here and is noted to be greater on this patient's left than on his right side. While assessing rotation, especially external rotation as shown here, be sure to prevent pelvic motion, which can falsely exaggerate range. Ensure you document the examination carefully so you can notice changes between serial examinations as they occur, especially in range of motion. It's important to remember that in many cases, change over time can be just as significant, if not more so, than absolute measurements, so serial examination should be performed and recorded. For health professionals less comfortable with clinical examination, focus on the sitting and lying position, limb lengths and Galeazzi tests, and abduction range, as well as any signs of pain. All children with CP should be monitored for hip displacement, but be extra vigilant in higher risk patients, such as those who cannot walk without assistance, or at all, those who have a spinal deformity, or those who have abnormal hip position or range. In children with concerning or deteriorating clinical findings, including problems with function or comfort, order an AP pelvis X-ray and consult with a pediatric orthopedic surgeon regarding next steps. In addition to clinical examination, proper X-ray screening is an essential component of early detection of hip displacement in CP. Refer to CP hip surveillance guidelines for your region for further information, or consult with a pediatric orthopedic surgeon if you have any questions. Remember that proper monitoring includes serial physical examination and serial X-rays, where recommended frequency depends on the GMFCS level, with screening beginning at the age of 2 years. Further details and recent modifications to the care pathway for CP hip can be found on the website for the American Academy for Cerebral Palsy and Developmental Medicine, or a similar organization in your region of the world. In CP, even if the clinical examination is not concerning, if the X-ray demonstrates hip displacement, they should be referred to a pediatric orthopedic surgeon for assessment and possible treatment. Your patient may benefit from further assessment and potentially surgery. Further details on how to interpret an AP pelvis radiograph can be found in our module on hip X-ray evaluation in CP. Working together, we can help ensure children with cerebral palsy are able to function comfortably at their maximum potential. Further educational materials on this and related subjects can be found on the website of the Hip Hope Network. Please note that the material presented in this video is strictly for educational purposes and is not intended as medical advice to patients or their families, and should not be used as a substitute for proper medical assessment. Thank you.